Hi, guys. My name's Kristen Lake. I'm the co-founder of Vetmetology. Thank you so much for coming tonight for Cory Woliver's gold standard treatments of snakebite envenomations in dogs and cats. This is our other co-founder, Brian Goldman. Say hello, Brian.
Hello, everyone. Hi, everyone.
All right, so we're going to get started here in just a moment with Dr. Cory Woliver of University of Florida, as well as a national snakebite support expert. Okay. All right, Dr. Woliver, take it away.
Perfect. I guess before I get started, it only says one attendee at the bottom. Is that correct? I don't want to get started if there's only one person. You're muted, Kristen.
I don't think so. Let's see here. I think that's probably a site issue.
Okay.
Yeah. I will check in on that though and let you know.
Okay. Sounds good.
Okay.
All right. Let's get started. So, hi, I'm Dr. Cory Woliver. I'm a clinical lecturer at the University of Florida in emergency and critical care. And I'm a staff vet at National Snakebite Support and with the Asclepias Snakebite Foundation. And yeah, let's get started talking about snakebite treatments and with North American snakes. Alrighty, so the main family or subfamily of snakes that we'll see is the subfamily Crotalinae. These are your pit vipers that have these heat-sensing pits on their face, and they range in size pretty significantly. Really small, like 20 inches or so, for like pygmy rattlesnakes and things like that, up to 96 plus inches for like eastern diamondbacks and things along those lines. You'll have your Crotalus, Cistrus, and Echistrodon. Crotalus is your rattlesnakes. Cistrus is your pygmy rattlesnakes and Massasaugas and things like that. And then you have your Echistrodon, which is your water moccasin and your copperheads and things like that. They have sharp retractable maxillary fangs. They're called solenoglyphus fangs. And they're basically like hypodermic needles. And when they bite, they'll puncture. And you can kind of see on this next slide that they have a main venom gland and then a compressor muscle that kind of squeezes that, and that goes through the duct, through the fang itself, and it is what causes the envenomation. In rear fang snakes, you'll have a Duvernoy's gland. So this is like your hognose and water snakes and things like that. And these guys do have to chew in order to get venom into the victim. Alrighty, so these are just some of your common snakes that you'll see here in North America. So top left is eastern diamondback, top right is pygmy rattlesnake, bottom left is a copperhead, which is probably one of the most common snakes you'll come across, and then bottom right is a water moccasin or cottonmouth. And then this is just some posters and some pictures of basically all of your your Crotalinae snakes. So identifying a bite is basically your first step. So has your patient been bitten? So if you have a pit viper that's bitten your patient, such as a rattlesnake, most likely you're going to see puncture wounds. You're going to see swelling / edema. You'll see erythema or often bruising, bleeding, pain, and then as time goes on, you'll see a little bit of tissue necrosis. But sometimes with these guys, you'll also see pretty profound shock, and that's something that's pretty common with these guys, and it just kind of depends on the severity of the envenomation. Where coral snakes, you're almost never going to see a puncture wound on them. It's really, 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 really rare. However, over time, they develop weakness, they become tachypnic, they'll vomit, they'll be drooling, they'll be just really lethargic, and then eventually develop tetraparesis and hyporeflexia. And then with non-venomous snakes, you'll probably never even know that they were bitten, similar to a coral snake. If it's big enough, you may get some puncture wounds, but you're not really going to get any clinically significant bleeding. It's not really going to be painful, and it's something that you can just wash with soap and water. This is pretty common, presentation for a lot of these, pit viper envenomations. So you get these really, really, really swollen faces. Dogs really like to be curious, and they'll stick their face in the snake's face, and they commonly get bit there. This bottom middle one is a cat that was bit, and cats are often swatting, pawing at the snake, so they'll often get bit on their paws. Perfect. So these are some of the common pit viper venom components that that we deal with in these species, and they often have a wide variety of these. Some will have them, some won't. There's even variation of venom in individuals of the same species. So you'll never quite get the same venom makeup. Big things that you'll see are like snake venom metalloproteinases and snake venom serine proteases, and those guys typically cause coagulopathy. A lot of them cause platelet aggregation, and then inhibition of smooth muscle contraction. And then things like bradykinins will lead to profound hypotension. Hyaluronidase will cause tissue destruction, and then myotoxins will cause things like severe muscle necrosis and edema and like twitching and things like that. And then phospholipases are probably one of the most common things that you'll see in most snake venom, and there are tons and tons of different phospholipases, leading from myonecrosis and edema and inflammation, as well as neurotoxicity and hemolysis and things like that. So starting with some diagnostics. So gold standard would be, let's get a CBC chem, PCV total solids, full chemistry panel. If you have the ability to run a CK, that's great to check for signs of muscle damage. If you have a PT-PTT, that's perfect. If you only have, in our facility, we use an ACT or an activated clotting time, and that does a really good job at telling us if these patients are coagulopathic or not. Also, if you have something like a TAG or a VCM, they're a little bit more time consuming to figure out if your patient's coagulopathic, but you could use something like that too. And then it's always good, especially if you're not 100% sure, to just check a blood film and look for echinocytes. You can count platelets. If you're not sure and you see echinocytes, I would be lenient. Well, echinocytes can happen from just about anything. It's very, very common to see them with snake bites. So that will certainly help support your diagnosis. And then the top three here are the different antivenoms that we have available to us in veterinary medicine. Venom Vet and Rattler are the most common. The one in the far right that says antivenin on it is the BI product that has just recently been discontinued in the past couple of months. So we're not going to talk too much about that. And then the bottom is the human products. So you have Anavip, you have Crofab, you have Naxav, which is the North American coral snake antivenom, and then we have this product here, the ICP anticoral, which is what we import from Costa Rica in order to treat our coral snake bites. We'll start with Venom Vet. It is a product that's equine in origin. They come in 10 ml vials. You have to refrigerate them, but they do have a 3-year shelf life. So most places where you have snakes, you'll probably see, at least one bite every 3 years. So having a vial or two on hand, it's unlikely that it would expire during that time. And it does need to be refrigerated. The cool thing about this is that it's a Fab2 molecule. So the FC fragment, and I'll get into this a little bit later, but the FC fragment's been removed. So there's less antigenicity and there's less likely to be a reaction because of that. Typically, you'll dilute it in saline, although you can dilute it in pretty much any fluid. And based on a paper that we'll just look at a little bit later on, the reaction rate was about 3.5%. And, that ranged from, mild hives or swelling up to, anaphylaxis. Rattler, also known as Antidote 3, is also equine in origin. This one isn't quite purified the same way VenomVet is. So this is suspended in equine plasma, and it is a full IgG molecule. So it has the Fab2 and the FC fragment. Also has a 3-year shelf life. This one you keep frozen until you're ready to use, and then you thaw it. Thawing doesn't take super long. When you do use it, you should be using a blood filter because it is a blood product. The product inserts recommend about 1 to 2 bags, usually recommend stopping after like 2 bags or so. However, if your patient needs more antivenom, without hesitation, continue to give it. The reaction rate for this one was about 9.3%. This is ACP and equine origin. It's a purified full IgG. So reaction rates ranged in this one. For dogs, I think it was somewhere between like 5 and 10%. And then with cats, I think it went up to about 20%. And I guess just swinging back to this product right now is not currently approved for cats, although we use it in cats all the time and we find it to be incredibly safe and almost never have any reactions at all. This product is approved for cats, but being a full IgG molecule going into a cat, and cats, when they go into shock or anaphylaxis, they do tend to have respiratory issues. It does worry me a little bit, but it can definitely be used. And if you have a sick patient that needs antivenom without hesitation, go ahead and use it. In terms of making antivenom, the way it typically works is the snake will get milked. The venom that's milked from the snake will get immunized typically into a horse. The one that changes things a little bit is Crofab for people. That one goes into sheep. You draw blood on the patient. It goes through some sort of centrifugation, plasmapheresis type situation to separate the plasma from the blood cells. And then you'll separate the antibodies out. You'll concentrate the antibodies. And then depending what you're using, you can use something like pepsin to, cleave the Fab2 portion from the FC fragment. And then you can, put it into formulation. And then this just kind of looks a little bit more at the different fragments. So the one on the left is the full IgG molecule. It has both the Fab2 and then the FC fragment. And then you have the split up products. So VenomVet is a Fab2 in human medicine. The product Anavit is a Fab2. And then when you go to Crofab, that is just the Fab fragment. So they'll further cleave that with papain, and that will make it into a Fab fragment. So when it comes to treating snake bites, antivenom is the only thing that can neutralize circulating venom. So the amount of antivenom you give is based on the amount of venom that was injected into the patient. The big question always is, how much venom was that? And, based on patients' clinical signs and vitals, as well as blood work and things like that, you can kind of get an idea as to how many vials this patient may need. Sometimes it's 1 vial or 2 vials. Sometimes it's 5, 10, or 20 plus vials. And it really just depends on the severity of the bite. In cases with severe coagulopathy, with bleeding, with hypotension, we'll often load them with about 4 to 6 vials right off the bat within the first anywhere from 10 minutes to an hour, just depending how fast they need it. And then sometimes we'll follow up with maintenance dosing of like 1 to 2 vials every 4 to 6 hours if the patient seems to need it. With Rattler, typically recommend giving 1 bag at a time, but again, just like VenomVet, it can be rapidly bolused if needed, and you can give multiple bags if needed. Just monitor for signs of reaction. Anaphylaxis overall is pretty rare, but it's definitely something to look out for. And whenever we start antivenom on a patient, because it is a foreign molecule going into the patient, we typically pull up a dose of epinephrine to have sitting on the patient's cage so we don't have to scramble for it if something happens. With dogs, we'll typically mix up 1 or more vials and 50 to 100 mils of saline. With cats, we try to mix up smaller amounts because cats are really tiny. This also goes for small dogs. So 25 to 50 mils of saline. This is specifically for Venom Vet or if you still have the ACP product. The Rattler product, you just thaw, you put it through a blood filter, and then you give it that way. You don't have to dilute that at all. But because it comes in 50 mil vial or 50 mil bags, if you need multiple bags on a small patient, you just have to keep in mind of the volume you're putting into that patient. Awesome. So we'll swing over to the algorithm here, and let me just pull this up on my iPad so I can make sure I hit all the key points. So this is something that I designed and hopefully plan on publishing at some point in the next who knows what time frame. So we made this for National Snakebite Support, and basically it is similar to the unified treatment algorithm that they use in people. We kind of guided our recommendations based off of that, and it covers mild, moderate, severe, and then minor envenomations as well. So kind of starting off with your patient, perform a full physical exam. If the patient will tolerate being shaved, go ahead and do that. Obtain your labs. So CBC, chemistry, coags. If you can do a blood film, great. And try and get a blood pressure. And, make sure that you still think that this is truly a snake bite. So puncture wounds, bleeding, pain, bruising, redness, prolonged coags, and then look for systemic signs of shock, neurotoxicity, significant bleeding, vomiting, diarrhea, tenesmus, things like that. Those are all signs that your patient's potentially shocky and, may need more aggressive therapy. If you're seeing signs of very early or immediate necrosis, that's, there you go, with another indication that antivenom is very likely needed in this case. And then another thing to monitor for is pigmenturia. So you want to make sure that, your patient isn't developing, hemoglobinuria, myoglobinuria, things that are going to damage the tubules in the kidneys. And because you don't know if your patient's coagulopathic, you're going to want to avoid a cystocentesis for sure. This would be free catch or, gentle catheterization. In terms of indications for antivenom, so you're going to look for signs of progressive swelling, local tissue injury, and then things like chemotoxicity and neurotoxicity and stuff like that. So with a mild envenomation, you'll see mild to moderate pain, mild to moderate swelling or bruising. You're not really going to see any coagulation or platelet abnormalities, or if you do, they're very, very minor. There's no systemic bleeding or bleeding from sites other than the puncture sites, and then you're not seeing any signs of hemolysis or GI signs or anything like that. Whereas with a moderate bite, you're going to get more significant pain, more significant swelling and bruising. You may start to develop necrosis and things like that of the tissues. You're going to have prolonged coags. You're going to start to develop significant thrombocytopenia, and then you may have a patient that's mildly to moderately bleeding from their puncture wounds, versus a severe bite where we have a very unstable patient. And I have a case report that I wrote up that I have a couple of slides on at kind of towards the end of this part that we'll kind of go over the severe side of things here. So unstable patient, they're hypotensive, they're obtunded, or they could have evidence of neurotoxicity. They're dysmic, they have severe bleeding, coagulopathy, they're vomiting or having hematemesis, diarrhea, hematochezia, things along those lines. Those would worry me that we have a more severe systemic envenomation. And then if none of those things are present, it's possible you have a minor envenomation, which in that case, I probably wouldn't administer antivenom. That's where I would observe the patient for. In humans, I recommend 8 to 12 hours. I say anywhere from 12 to 24 hours, I think, is fair. If it's really minor, you're not really seeing anything, and the owner's comfortable monitoring at home, they're not far from the hospital. If something does change, I think that's fair to have them watch it at home as long as they are closely watching it. And then if they do stay in the hospital, repeating labs at the 4 to 6 hour mark, and if all looks good there, go ahead and discharge. When it comes to dosing VenomVet, which would be VenomVet or ACP, which would be the left-hand side of box 4, you dose, again, based on the severity of envenomation. So mild, you do like 1 to 2 vials over 1 hour. Moderate, you do anywhere from like 2 to 4 vials over like 30 to 60 minutes. And a severe envenomation, which is what at UF we see a lot of severe envenomations, especially from eastern diamondback rattlesnakes. So it's not uncommon to give antivenom pretty rapidly. So anywhere from 2 to 6 vials over no more than 30 minutes, kind of get the initial signs under control. And then clinically, you'll see the more aggressive you are up front treating it, honestly, sometimes the less antivenom you have to give overall. And, the patient outcome tends to be better because they're not shocky as long, they're not showing signs of neurotoxicity, you correct their platelets, you correct their coags. So things like that is really important when dealing with a severe envenomation specifically. Versus rattler antivenom, again, this must be given through a blood filter. For a mild envenomation, I'd give a bag over an hour. For a moderate, I would do a bag over like 30 to 60 minutes. And then a severe, I would do like 1 to 2 bags over no more than 30 minutes. And then again, just monitor for adverse reactions. If you're seeing something that looks like an adverse reaction, you would jump over to box 14. So monitor for signs of urticaria, angioedema, circulatory collapse. You'll see GI signs more common in dogs with like shock gut and things like that, and then more commonly respiratory distress and collapse in cats. You'll typically start with 0.01 mils per kg of epi-IM, and then you'll start a CRI typically around 0.05 mics per kg per minute, and you can titrate up a pretty good amount on that, depending how hypotensive your patient is. I would also like to give diphenhydramine, 2 to 4 mg per kg IM. If they're really, really coagulopathic, I'd probably give it sub-Q as opposed to IM so they don't bleed into their muscle. And if it's really, really, really bad anaphylaxis, consider a steroid, but would make me a little bit nervous in a really shocky patient. So kind of swinging back over, what you're going to want to do is determine, has control been achieved? Is the swelling and tenderness not progressing, or is it starting to go away? Blood work resolving? Are they becoming stable? Is your patient, no longer obtunded? Are they gaining their reflexes back? Things like that. If that's the case, performing serial exams on the patient, rechecking for swelling, rechecking the wounds, rechecking their pain scale, monitoring their blood pressure. And then as long as they seem stable, rechecking labs in 4 to 6 hours. You can do it sooner if you think things are changing at any point. Don't ever hesitate to say, I'm not quite sure what's going on here. Let me just recheck and see what's going on. And make sure that the patient, hasn't had a rebound of severe coagulopathy, or like if your patient starts bleeding from a separate site, like let's say they were bit in the arm and they start bleeding from their nose, like that's a huge red flag that they've had a severe envenomation. You can definitely also, if they're a little bit hypotensive, they're not quite responding to the antivenom itself, you can definitely give them some fluid boluses and things like that. Generally, anywhere from 5 to 20 mils per kg, and just be cautious of fluid overload. You will, if you're not getting these things resolved, you'll keep repeating. So box 11 would be additional antivenom. You'll repeat steps 4 and 5 until control is achieved. And again, just be cautious of fluid overload in cats and small dogs. If they've responded favorably to everything and their labs are normal, the patient's normal, you can consider discharging them at that point if there's no progression of venom and, no unfavorable laboratory trends. There's, basically discharge instructions right here that, you could, integrate into your own discharges for your patients. So monitor for necrosis, pain, things like serum sickness is important to look out for, which is generally, it's a delayed hypersensitivity reaction. It generally happens 5 to 7 days or so, but up to 2 weeks after they get a foreign substance in their body. It'll be rash, vomiting, diarrhea, joint pain, fever, things like that. It's not life-threatening. It's just uncomfortable for, a couple of days to, a week or two. And then, making sure that they're going home with decent pain meds if they're painful. Ranging fentanyl patch, codeine, gabapentin, tramadol, depending where you fall in, if tramadol really works or not scale. And then, if there's a significant wound or necrosis that needs to be managed, following up, either with your primary care vet or if it's severe, refer to a specialist for wound care. For patients that have had a severe envenomation, we'll sometimes see like a rebound type envenomation, or a re-envenomation is what we'll sometimes call it. Or persistent envenomation is the other word for it. And that can happen generally 2 to 3 days after being discharged. The thought behind it is that as the swelling goes down in their face or their arm or wherever it is, generally it's the patients that have been bit in the face. As that swelling goes down, it might release a small pocket of venom that was kind of walled off. And then that goes systemic. The patients become coagulopathic and tachycardic and weak and everything again. So rechecking blood work to try and catch that before that gets bad is often important, but a lot of times the owners notice something's not right and they bring them back in. That's definitely something we mention for, all of the severe bites. Big things to avoid, probably more important than almost anything is, avoiding things like NSAIDs, steroids. So NSAIDs are totally contraindicated in snake bites. Steroids are controversial, but definitely not recommended. There's no strong evidence to support their use. Benadryl just doesn't do anything typically. There's very, very little histamine release, if any, in most of these bites. Some of like the European adders and things like that will sometimes release bits of histamine that can be clinically important, but in most of the North American bites, unless your patient is having a true anaphylactic event or an anaphylactoid event from the bite itself, then that's something to avoid. Don't do a fasciotomy. Don't put ice on it. Definitely don't do a tourniquet. And then people will cut and suck on the bites, and electric shock. Those things don't work. They cause more damage. And then prophylactic antibiotics are not needed. And I'll kind of get to that a little bit later. That covers most of that. So let's move on here. So fluid therapy is important. You want to correct hypovolemia and hypotension and dehydration. A lot of these patients will become severely hemoconcentrated in third space, a lot of their intravascular fluid. And making sure that their kidneys stay perfused, as pigmenturia is definitely not uncommon after a snake bite. They're also extremely painful. I'm a big fan of, I think that they should get pain meds. I definitely work with some doctors who don't think that, especially in the initial stages, sometimes that's controversial, because sometimes it can mask their clinical signs and they can decompensate. But when I give them, I usually give them something strong but reversible. So methadone, fentanyl, things like that, that if the patient starts to decompensate, I can reverse that. Things like butorphanol or buprenorphine may not be best in these situations, because butorphanol is, you can use it as a reversal. And then, buprenorphine being a partial agonist, it makes things tricky. And, if you want to use something else afterwards, that will, it causes problems with that for a while as well. in severe cases, you may need to, throw some blood products at them. So if there's, significant bleeding, your patients, hemorrhaged a good amount of their, intravascular volume, a good amount of their red blood cells, you may need to give them packed red cells or fresh whole blood. You can give them fresh frozen plasma as well. Generally, that doesn't, that shouldn't be used to treat the coagulopathy, because that can be adding fuel to the fire. But if you are treating the coagulopathy, or sorry, if your patient has become hypoproteinemic and is maybe starting to third space because of that, something like fresh frozen plasma or cryopore plasma or something like that can definitely be used. And if your patient's dyspneic, definitely provide oxygen, or, if they're bleeding into their airway, certainly intubate them and ventilate them. I have a question here. What concentration of epinephrine? Geez, I may have to get back to you on that. I think it's the one that comes out to be a mg per mil. But I haven't thought of that in a really long time. Maybe you can.
It's on the algorithm, Woliver, as 0.01 mils per kg IM undiluted, and then a CRI at 0.05 mics per kg per minute, and then titrated up as needed.
Yes. Yeah, the question was, what was the concentration? Is it 1-to-1?
Oh, the concentration of it. Okay.
Yeah. So I can't remember what we use at work, so I kind of just went off of that, and I completely blanked that there are other concentrations of epinephrine.
Yeah, it's usually the 1 mg per mil.
Yeah,
But that's not to say every hospital.
Right. That's what I was basing it off of. That's what we have at our hospital. So that's what I would reach for. Cool. So after a patient is discharged, pain medications, there's a wide variety of what you can use. Tramadol, gabapentin, they're not the greatest pain meds, but for mild pain, sometimes even moderate pain, they can do okay with that. But for more severe pain, where like a patient has had severe necrosis, or like they've had some muscle necrosis, and they're super super painful, something like a fentanyl patch is really good, or sending them home with acetaminophen with codeine, or a combination of these products. That's always helpful. You may need to do some wound care. And then again, hypersensitivity reactions can happen. They're rare. Just monitor closely. Back to what was I going to say now? Oh, yeah, acetaminophen, when you use that with codeine, make sure it's just in dogs, not in cats. There's not really a great way to get a safe dose of that for cats. Cool. So kind of going over the allergic reaction thing again. Again, potentially see urticaria, angioedema, circulatory collapse, all that stuff. Evidence of shock gut for dogs. And respiratory distress, bronchospasms in cats. You can sometimes see either one in either species. Just kind of depends the patient, but most commonly that's what you'll see with these guys. And then back to the epinephrine thing. Typically, I just kind of dose this off of what you would see in the Recover guidelines, where they'll tell you to pull up 0.1 mils per kg. And I do believe that's based on the 1 mg per mil concentration. And then diphenhydramine plus minus an anti-inflammatory dose of steroids. Big things. NSAIDs are contraindicated. The big reason I like to say that is in human medicine, they mostly say, don't use this because it can worsen your bleeding. We don't totally clinically see that with dogs and cats. However, NSAIDs can definitely lead to acute kidney injury in cases. So these patients are often hypotensive, or they're hemolyzing their red blood cells, they're developing rhabdo, they're developing pigmenturia, and you have this hypotensive pigmenturic patient that you now alter renal blood flow to with an NSAID, and it's just a recipe for frying the kidney. So I'm not against reintroducing an NSAID to the patient, generally 3 to 5 days in, as long as their blood work looks good, they've got no signs of ongoing envenomation, the patient's clinically stable, urine looks good, things along those lines. There are multiple studies that show glucocorticoids are of no benefit. In some snake bites, they may worsen the outcome as well as immunosuppress. The other thing that I worry about with steroids is, again, we'll often have shocky patients. We give something that can lead to, ulceration of the stomach wall and, or, any gastrointestinal ulceration. And, they're not recommended typically for that reason. Benadryl, this is more of like an at-home thing, or even if, you have a patient come in with a, mild to moderate envenomation, just giving them diphenhydramine and some pain meds and sending them home isn't going to do anything. So the swelling isn't because of, histamines. It's because of all of those things that I, had listed on this slide. So, there's, the antihistamines aren't going to reverse those. And then antibiotics aren't indicated unless you have a patient that's got immediate active necrosis. The snake venom actually kills a lot of the bacteria at the injection site, so infection is not generally an issue in the acute stage. However, if necrosis occurs, antibiotics would totally be indicated at that point. There is a study that I show later that only 1% of cases with rattlesnake bites develop necrosis, which is exactly what they found with human medicine as well. So important things not to do. So this was a post that we had on National Snakebite Support that one of our administrators kind of gathered all of the crazy recommendations from people who have posted saying, hey, your dog was bit by a snake, or you as a person were bit by a snake, you should do this. And, electricity, so like hooking yourself up to a car battery and shocking yourself is not a good idea. Any sort of urine is not recommended for putting in or in a snake bite, on a snake bite, in you, anything like that. Turpentine, gunpowder, raw eggs, lemon juice. I've seen a lot of people be like, raw bacon and eggs will often, act as like a salve to like pull things out, and like that doesn't work. Don't do that. It's just setting you up for failure. But this was a very amusing post. And I can't believe that people have come up with these recommendations over time. So, in the vet med world, we have the Crotalinae atrox toxoid. So, Western diamondback, rattlesnake. Basically, what they do is they came up with this vaccine or toxoid to kind of stimulate the body to recognize when a snake were to bite you. The goal was originally to buy some time to get you to the vet or decrease the amount of antivenom that's needed. But this is the AHA statement down here saying that there's absolutely no evidence to support that this will be helpful in any way, shape, or form. The idea behind it is great. Like, if this was something that was truly successful and truly worked, it would be great, because it could either buy you time or ride it out at home. But at this point, there's no way for this to kind of work that way, because your body will never be able to make enough antibodies at the time of the envenomation to neutralize that, which is the main reason that we just have no evidence that this currently works. There are some studies in mice where they used extreme doses of the toxoid, and it helped the mice, but I mean, the doses were much, much, much higher. Like, I think anywhere from 50 to 1,000 times higher than what we would be using in dogs. So it's a great idea in theory, but unfortunately, no evidence to recommend it. And there's a potential anaphylaxis risk if given ahead of time and then a patient is bitten, which is this paper right here. So there were 2 dogs seen, I believe this was at CSU, where they had previously been vaccinated, and both dogs showed up in full-blown anaphylaxis. at which they suspected was likely the priming event was likely the toxoid. So both patients survived. They ended up doing fine, but it was just adding a little bit of insult to injury there. This paper here basically is a paper out of UF. It's just kind of a discussion of what treatments are good, what treatments are bad, what recommendations we can make, and that overall the prognosis for these guys generally is pretty good, but a lot of it also depends on the snake and how well we can how we're able to treat it and things like that. So prognosis range from about 1 to 30%. They did state that there's no evidence to support glucocorticoid use or NSAID use or antibiotic use or anything like that. That did not change the outcome of these patients. This one looked at basically compared three different antivenom types. The majority of the dogs, no matter what antivenom product they got, survived. So all of them are overall safe and effective. But it did, the big conclusion with this is that the IgG products did have a much higher reaction rate than the Fab2 product. So this was another one out of UF. Let me hang on 1 second. So this one basically showed, so out of the 56 dogs that they identified that developed an AKI, so sorry, 16 out of 56 dogs in the study developed an AKI. 5 of those 16 survived. 7 of the 16 died, and 4 of those 16 were euthanized. So the majority of them that developed an acute kidney injury did not survive. Comparing it to the patients that didn't develop an AKI, kind of more of a control group, 39 out of the 40 dogs in the non-AKI group survived. So if you are bitten by a pit viper and you develop an acute kidney injury, prognosis is pretty guarded at that point. So it's important to keep an eye on, the patient's creatinine and BUN and, urine output and urine color and, things along those lines that, may put them at risk for, and, hypotension, things that'll put them at risk for developing an acute kidney injury. This paper looked at a bunch of dogs. A couple of the dogs in the study were vaccinated with the rattlesnake vaccine. It showed no protection. It also stated that the Fab2 antivenom had a low risk of acute hypersensitivity reaction, which is pretty nice. And then overall, glucocorticoids, diphenhydramine antibiotics, and the vaccine was not, the use of those was not supported in snakebite treatment. And then this paper was just the one that showed that there's about a 1% chance of developing an infection with a rattlesnake bite. So it can, again, you can develop necrosis and things like that, but that would hopefully be mitigated by using antivenom appropriately. And then this is a paper that just showed that I think this dog got 2 bags of Rattler after getting bit by a prairie rattlesnake. And then about 2 weeks later, I believe they developed signs of serum sickness. So edema, hives, GI signs. They did skin biopsies to, truly confirm that there was a vasculitis secondary to this serum sickness. And they were able to actually confirm that this was truly a serum sickness this way with this, with the new product at that time. So it's just something to look out for. I mean, if a patient develops serum sickness, again, they're really uncomfortable for a couple of days, but it's very, very, very unlikely to be life-threatening or anything along those lines. So just something to keep in mind. You shouldn't be afraid to use anti-venom is kind of my point with all of these, that overall it's very safe. Reactions can happen just like they can with anything else, such as antibiotics or, whatever it may be. So don't hesitate to use anti-venom if you think your patient needs it. So this is a case that I saw as a 2-year-old female intact dachshund. It was bit by a timber rattlesnake or a canebrake rattlesnake about 45 minutes prior to presenting to me in the ER. This is actually the snake that bit her, and she presented in really rough shape. So she had 2 puncture wounds over her left eye. She had mild swelling. She had an absent palpebral reflex, so she had full facial nerve paralysis on the left side there. She was dull to obtunded. She was paretic. She had weak femoral pulses, and she was ridiculously tachycardic at like 220 to 240. One of the cool things that she had that we'll sometimes see with timber rattlesnake bites is that she had myokymia in her hind limbs, which is a fancy word for muscle twitching. And she did present with urticaria on her dorsum, which I thought was a little weird. The owners live like very deep in the woods, and I was like, well, maybe this is from the snake bite. Maybe this is from some insect bites. Mosquitoes are so common down here. So I did end up giving her some Benadryl on presentation, which kind of hurt my soul a little bit, but it felt like the right thing to do at the time. When I did give it so we'll see her lab values on the next page, but her ACT, normal ACT value is 80 to 120 seconds. Hers was 999 seconds. It was too prolonged for the machine to read. So I was a little hesitant to give it intramuscularly, so I gave it to her subcutaneously. So you could see her heart rate was really high. Her clotting times were really high. She had too low of a blood pressure to obtain. It's probably really hard to see a lot of these values, but the main takeaway here is that she did have evidence of echinocytosis. None of these changes were super clinically significant, but she was really sick. She was unable to move, and timber rattlesnakes in this area, right where we are on like the Georgia-Florida border, have both type A and type B rattlesnake venom. So meaning that they have both a neurotoxin and a hemotoxin as well. So they will cause both bleeding and anywhere from twitching to paralysis. And we kind of saw all of the above in this dog. So this is the video of her myokymia. You can see her muscles spasming away, and you can see how out of it she was. Her heart rate was pretty darn high as well. So we treated her pretty aggressively. So we have to run down to pharmacy, which is on the other side of the building, to get anti-venom. So we bolused her 2 20 mil per kg boluses of LRS while we were getting the anti-venom. We gave her the diphenhydramine. We gave her some Serenia. And then I bolused her 2 vials of Venobec because she was very much decompensating right in front of our eyes. So I bolused it very quickly over probably like 2 minutes. And then we gave her an additional 2 vials over 30 minutes. We ended up giving 1 more vial over about 4 hours. I was going to plan on giving a second one, but at that point, her clotting times had resolved and she was up and alert and everything like that. She was still unable to blink her eye at that point. I transferred her to the ICU at that point because I was working the ER, and she was still pretty sick. And she started to develop hematochezia. So the ICU resident put her on Unison and pantoprazole for gastroprotection, and just so we didn't see any signs of GI translocation. And antibiotics I would not typically reach for, but in this case, I did not want her to potentially die of sepsis, based on how shocky she was. So we went ahead and did that. This was probably 2 hours after presentation, 2 or 3 hours after presentation. She was still getting anti-venom, but you can see very, very, very mild swelling, but she's up, she's alert, and she was, definitely feeling much better. The cool part about her was that when the owners went home to go check on their other dog, they found out that the very large Doberman that they lived with had also been bitten. So they brought him in. That dog was very stable. Its clotting times were normal. It had a little bit of swelling. We gave it a vial of anti-venom and sent it home. But when that dog walked in the building, the dachshund, finally, that was like the point where she's like, I feel better. So she stood up and walked over to the edge of the table and wagged her tail, and they like interacted with each other for a minute. So that was really cute. She came back to see our optho team about 2 weeks later. And she got her blink back. So she had a full recovery of her palpebral reflex, which is pretty cool. We were hoping that's what we would see, and that, the fact that basically we think that the venom components acted directly on the facial nerve there, causing the paralysis. And as that went away, her blink recovered. So that was that. So what do we have time wise here? 20 minutes. So we'll go into coral snake envenomations. I'll probably do this pretty quickly because most people in the US don't end up treating these, and unfortunately no one else really has antivenom for coral snakes except us. So that makes treating these guys tricky, and basically in a nutshell, it's all supportive care, and very often they'll just need to go on the ventilator, and there's a really good chance that once they go on the ventilator that they will survive. So these guys are a fossorial species. They tend to stay hidden under leaf litter, logs, etc. They stay pretty small, generally more in like the 20 to 30 inches side. I actually was just at the facility where they milk the coral snakes for the human version of the antivenom, the North American coral snake antivenom by Pfizer, and the guy who runs that facility had a 48 or 49 inch coral snake, which is hands down the biggest one I've ever seen. It was humongous and super cool to see. Very commonly, they'll have black heads, followed by yellow, and then they'll have alternating black, yellow, and red rings. But the black head's pretty important, as a lot of these guys will have some aberrant colorations, and people will very commonly confuse them for other snakes. There's a rhyme. I hate the rhyme. Most herpetologists hate the rhyme because people generally recite it incorrectly. And contrary to popular belief, these guys do not have to chew on you in order to envenomate you. They can just nick you with their fangs, and you can get a full dose of venom that way. So they have very small fixed maxillary fangs, which is proteroglyphus. You can kind of see these here in the images, how tiny they are. And it just takes one tiny little bite, and it only takes a really small amount of their venom to really cause a problem. There are 3 species we have here in the U.S. So we have the eastern coral snake, which is the one we have in Florida. It goes up to like southern North Carolina and like up to Louisiana. And then you have the Texas coral snake, which looks exactly the same. For dogs and cats, for their purposes, their venom is as potent as the eastern coral snake. But for humans, when they get bit, it tends to just be pain, and they'll just go to the hospital and get treated for pain. And then there's the Sonoran coral snake, Micuroides urixanthus, which is very, very, very shy, does not like to be around people. And these guys are, out of the 3, are the least toxic. They're also the smallest. So they have a much smaller venom yield, which we think plays a big component in that. To my knowledge, there's never been a recorded case of a Sonoran coral snake bite, and definitely no deaths in both people and in animals. So this is what makes them so toxic. So they have phospholipase A2, which does many different things within them. So it causes intravascular hemolysis, causes hemoglobinemia, myoglobinuria, rhabdomyolysis, and it's also thought to be the main component of the neurotoxicity, containing both pre- and postsynaptic neurotoxins. There's also the alpha neurotoxin, which is a 3-finger toxin. It blocks the postsynaptic nicotinic acetylcholine receptor, further leading to lower motor neuron paralysis. So now that we know that, that's kind of what we're dealing with here, the goal is to, treat these patients. The gold standard obviously would be to try and treat them with antivenom, but with it being so hard to, get antivenom for these guys, a lot of it comes down to supportive care. So we import our antivenom from Costa Rica. We have special import permits with both the USDA and with APHIS. And it is a very time-consuming process. It's not expensive to do, but there's a lot of steps to get it done correctly. And, it's just something that it can be done, but it's a lot of work to get it done. So the rest of the treatment would be ventilatory support. They often become recumbent, so recumbency care. They need a urinary catheter. They need IV fluid therapy to keep their kidneys perfused. Sometimes they can hemolyze enough to the point where they might need a blood transfusion, but that's really, really, really rare. And then, if severe enough, they can definitely develop an acute kidney injury. But again, that degree is pretty rare. So the coral snake antivenom is needed to slow or prevent progression of signs. It's really rare that we fully prevent them from becoming clinical for it. But the other thing is that once they're already paralyzed, you can't reverse it with the antivenom. It's only to prevent further clinical signs from developing. This is a full IgG molecule derived from horses that are hyperimmunized to a couple of different species. Micrurus fulvius is the main one that we have here in Florida. So the other ones are Costa Rican species. So the big thing with treating for these guys is that dogs and cats can't tell you if they've been envenomated. And we recommend that really any exposure should be treated as an envenomation. And based on the molecule sizes of some of these, toxins they inject, clinical signs can be delayed for quite some time. Generally, you'll see it within 6 to 12 hours, but it can be up to 36 to 48 hours that, it may pop up. And the longest I think I've personally seen was about 24 hours. Like, we were getting ready to potentially send this dog home, and then the dog went down in its hind limbs from it. So it definitely happens. The other thing is that you don't really, so again, treat with exposure. The way we'll typically do it is 1 vial if the patient is not clinical. So a dog walks in, it had a coral snake in its mouth. We can't really ever see where the puncture wounds are because their puncture wounds are so tiny. They're often somewhere on the muzzle, either hidden by hair inside their mouth, and it can be really hard to see. So if the patient is not clinical for it, they don't have any signs of hemolysis, they don't have any signs of weakness, their carbon dioxide's normal, we'll probably give them a vial at that point. If any of those things are abnormal, they're hemolyzing, they're weak, anything like that, we'll start generally with 2 or more vials and, kind of give as needed. If you were a human and you walked into the ER and you were bit by a coral snake, they would generally load you with 5 vials all at once and then monitor you for 24 hours or so. So ignore this top line here. That was not meant for coral snakes, but generally we'll mix up a vial in 50 to 100 mils. For dogs, 25 to 50 mils for cats. Typical administration is over an hour, but again, just like the Venom Vet or the Rattler, you can bolus and give undiluted if needed. Generally, 1 to 4 vials again. Most patients will develop some degree of tetraparesis. They'll generally go down in their hind limbs first, but they will become paretic often in some way. But the goal is to try and prevent them from needing mechanical ventilation. With these guys, steroids, NSAIDs have no benefit. I would still say NSAIDs are contraindicated because the phospholipase A2 causes hemolysis. And again, it's just adding insult to injuries to kidneys. Antibiotics are not needed for these guys. Again, you can't even find the puncture wounds most of the time. And I don't recommend Benadryl for these guys, as Benadryl can sometimes make patients a little bit sleepy, and it can make it potentially look like your patient is progressing in the wrong direction. So what I typically like to do is monitor their PCV total solids every 4 to 6 hours to monitor for signs of beginning or worsening hemolysis. You could also consider monitoring urine color for the same idea. And then if you're going to do that, walk them every 2 to 4 hours to monitor for weakness, paresis, ataxia, as well as monitoring their urine color. And then if they're recumbent, just recommend checking a PCO2 as frequently as needed to monitor for hypercapnia. So PCO2 of greater than 60 is ventilatory failure, which means they need to be put on the ventilator. So physical exam findings. It's really rare to find the puncture wounds, minimal to no swelling or pain. And then again, lack of these findings makes it really difficult to find, if the patient's truly been bitten. It's so hard to see, but this is one of the few dogs I've ever seen puncture wounds on. Right where that little arrow is, there is a tiny little blood spot on that dog. This dog was also particularly very sensitive in that area, which also isn't super common. But anytime we would touch that area, the dog would totally wince. And this dog did have evidence of hemolysis and, weakness and things like that. So we knew it was truly envenomated. I guess another point is, treating with exposure. It's giving antivenom when a patient hasn't been envenomated is still safe. It's not going to, likely do any harm. There's always a risk of the allergic reaction, but there's minimal, concern that anything bad's going to happen. So, common signs for dogs. Most dogs will show quiet mentation. They'll be drooling. They'll sometimes have muscle fasciculations. They'll vomit. 50% of dogs in one study showed vomiting, diarrhea, hypersalivation as their initial clinical signs. And then as the signs progress, you'll see tachypnea and dyspnea. They'll develop, tetraparesis and then decreased absent reflexes. With cats, the most common clinical signs were tachypnea and tetraparesis. Additional findings include absent spinal reflexes, altered mentation, bradycardia, and hypothermia. They can cause pretty severe hemolysis or rhabdomyolysis that leads to pigmenturia, which is what this dog, experienced after a really severe coral snake envenomation. Oop, what did that? There we go. So yeah, that dog got is a pretty big dog, like a 40 kg dog that got bit by a coral snake and sat around for most of the day. But we'll get to that case specifically. Other differentials for these guys that can be sometimes really hard to narrow down are things like tick paralysis, coonhound paralysis, botulism, fulminant myasthenia, and organophosphate toxicity. So the minimum database we'll get for these guys is venous blood gas. So we'll get a CO2, and this is just minimum. Like if you can do a full CBC chem, that's ideal, and then a venous blood gas. But getting a PCO2 level, get a BUN, creatinine, and potassium, and then checking PCV total solids. If you can get a CK, great. These guys will sometimes develop echinocytes as well, so getting a blood film and then getting a urinalysis as well. This patient you could do a cystocentesis on because they don't have any, clotting abnormalities. So dogs will commonly develop echinocytosis and hemolysis due to the phospholipase A2. Cats tend to be somewhat refractory to hemolysis, but they will definitely develop echinocytosis. So we have Fluffy here, a 4-year-old male castrated Rottweiler. He was left outside for approximately the whole day while the owners were at work. They came home. They noticed he was walking sideways and stumbling with his head down. They rushed him into us. By the time he got to us, he could not move at all, and they only lived about 40 minutes away from the hospital. On presentation, he had an increased rate, decreased effort, His reflexes were reduced to absent, really weak withdrawals. He was already showing signs of pigmenturia by the time he got to us. His PCV was hemolyzed, which is the main thing we really monitor with that. And then you can see that his CO2 is creeping up there. So like that PCO2 range of like 35 to 45 for a venous gas is, it's a small range, and it's something that you have to really monitor. But like once you start getting up to like 50, 55, 60, that's concerning that that's going to keep creeping up. The other thing is that his creatinine was technically elevated at 1.5 and his BUN was 42. Just more evidence of hemolysis. His pigmenturia was really severe. We immediately bolused him a vial of coral snake antivenom. He really seemed to do well for about 2 hours. Then out of nowhere, just acutely respiratory arrested. We immediately intubated him, and we put him on the ventilator, where he spent, I have it somewhere. He spent quite some time on the ventilator. We didn't continue to give antivenom after that. The owners were a little bit financial, and he was already on the vent. Like the goal is generally to prevent them from going on the vent. The rest of the signs tend to, kind of resolve themselves. So you can kind of see he was doing better, and then bam, CO2 of 67, 85, and I think his respiratory arrest was at the 67, and then even with ventilation, it kept going up a little bit, but then you could see that it started trending back down once we had him on the ventilator. He did develop a little bit of an AKI while he was with us. His CK was a little bit elevated, but nothing too crazy. That all got better. He did develop ventilator-associated pneumonia while he was being ventilated. Common thing to see. He developed a mild AKI, but nothing that required any intervention with like dialysis or anything. And he didn't end up having a blood transfusion, but he hemolyzed so much blood that his I forgot what his total PCV dropped to, but it dropped a pretty significant amount while he was there and was like teetering on a blood transfusion. So he got the one vial. He was on LRS. We placed a central line. His sedatives were ketamine, midazolam, propofol, and butorphanol for the vent. Serenia, pantoprazole, cisapride, Unison, Enro, mouth rinse, and then urinary care, and then he had continuous tube feeding with Gevity. After 72 hours on the vent, he was taken off and placed on flow by oxygen. He was discharged 11 days later. He was mildly paretic at discharge, but fully ambulatory. Total bill was around 12 grand. So pretty significant. 72 hours is much longer than the average patient goes on the ventilator for. The average patient is about 58 hours. So it just goes to show that he was a pretty severe case. So just kind of some articles. I don't know how much time we have, about 4 minutes. So I'll probably skip through these, but basically the moral of the story is that patients that go on the ventilator have about a 95 or so % chance of coming off and doing well. One other cool thing that is in the works is there's this drug that's a phospholipase A2 inhibitor. It can be given IV or orally, and it can even reverse the signs of, unlike the antivenom that just binds circulating venom, this can actually reverse the signs of the neurotoxicity and, can really, really, really help a patient. But this is still all in research. Cool. What questions do you guys have?
Okay, so let's see here. Hi, Cory. How often do you all actually see a reaction to antivenom, VenomVet, that warrants intervention with epinephrine? Is it directly related to the rapid infusion of a large number of vials in the case of VenomVet?
No, actually, we'll usually see it when we'll do and it's really rare that we see a reaction at all. But when we see it, they'll be on a regular infusion. They'll get like 1 ml or 2 mL of it, and then they'll generally vomit, collapse, have diarrhea like immediately. And then we just treat them for it immediately. It does generally prolong their hospitalization a little bit because it's an extra hit to them, but it's really, really, really rare that with any of the products we use that we see reactions.
Okay, thank you. Do you have data about the prevalence of snake bites in companion animals in each state/county? I want to know if it makes sense to carry antivenom at our urgent care clinic.
We don't. So the human side of things, they have something, I think it's called like the toxic database or something, where like a select group of physicians has access to it, and they have all of that, epidemiologic data on that. I do not, and to my knowledge, nothing like that exists in vet med. But I guess that's something where if you want to email me afterwards, I can figure out where you are and see if it's worth it to carry something like that where you are. But I would say at an urgent care, I think it would be reasonable, to carry at least 1 or 2 vials on hand. And then if it's a more severe envenomation, you could always refer to a specialty hospital after that.
Okay, thank you. Since there's no benefit to giving diphenhydramine to treat snake bites, will giving it prophylactically before administering the antivenom reduce the chance of adverse reaction to the antivenom?
No, I think there was a study that showed that with plasma, that when it was given before plasma, that it didn't do anything for, or any sort of blood products, that it didn't do anything to prevent reactions. However, if you were to pre-treat with epinephrine, which they'll sometimes do in a lot of countries, which I don't totally recommend doing, that actually does have a significant difference in preventing reactions. But diphenhydramine doesn't prevent anything.
Okay. Let's see here. And then the last question is, before the end of this lecture, can you address from where and how to obtain antivenom for coral snake bites and how you judge when to begin treatment?
So generally the patients, so I will basically, if the dog or cat has been exposed to a coral snake, then I will treat. So like if it's in their mouth, they were playing with it, pawing at it, anything like that, I will treat. I will give more if there's signs of hemolysis, weakness, lethargy, vomiting, anything like that, truly indicates an envenomation. But I would rather give a vial of antivenom to a patient that hasn't been envenomated than withholds antivenom for a patient that has.
Okay, perfect. Well, thank you so much, Dr. Woliver.
I think there's a second part to that.
Oh, I'm sorry.
Obtaining the antivenom is quite difficult. You have to get what's called a BBIND permit. I actually just went through this for myself, and it was like a 3-month process to like get it approved, 2-month process to get it approved. That's something that if you have questions about that, you can email me and I can direct you to the best source for that.
Perfect. And what is your email again?
I would say cory.woliver@ufl.edu would probably be the best one.
Okay, perfect. All right. Thank you so much. And we're going to go to the last slides here that we've got here from Vet Metology. Let's see here. Okay, these are our upcoming live webinars. So we've got treating working canine injuries in the field for first responders, advanced bandaging techniques with Brian Goldman, our co-founder and owner of Brian's Bandages, the complete guide to medical math for emergency and critical care veterinary medicine by myself, and ADHD and neurodivergence in veterinary professionals for leadership and support staff with leading veterinary teams, and the phone triage masterclass with Shadia Rayfedge from Vet Triage. Special considerations for veterinary staff working with service dogs and service dog handlers with Mike White. He is a veterinarian and medical director of Veg Falls Church, and vascular and intraosseous access and fluid therapy techniques in exotics with a very special guest lecturer that we will announce soon. Let's see here. All right. So to earn your certificate of completion, just go to www.vetmedology.com and subscribe for $10 a month. Navigate to your CE and complete the lecture quiz to earn your certificate. The webinar will be uploaded momentarily. So just give us some time with that. Let's see here. There's also a 10% off special with discount code EARLYBIRD for 10% off your first month subscription. Let's see. Please don't forget to take the survey on the right-hand side of your screen before exiting to www.vetmedology.com. Your feedback is very important to us. And thank you guys for watching. We appreciate your time. Have a good night and happy holidays.
Thank you.
Mm-hmm.